All right. Are we recording? Yeah, we are. All right, so when we talk about gas exchange, what are we really talking about if you look at your concept overview? Okay. So we're down to the part where when we breathe, it has to do something, right? So if it doesn't, then we develop a bunch of different conditions. And y'all have been through the mundane stuff, right? Y'all have been through the COPD and the asthma, right? Y'all have seen this before? Okay. So this is the fun stuff for me because I'm an ER nurse, and this is what I like seeing. You know, people that are all tore up and that kind of stuff. But it doesn't change the basic fact that you have to have, what do you have to have in order to have perfusion? You have to have gas exchange, and then you have to have what? You have to have circulation. Okay? If you don't have a delivery system or you don't have an oxygenation system, you're going to get a lack or a decrease in perfusion. And when you do, you'll see various signs and symptoms depending on what the issue is. But you have to know the difference in what you're looking for. All right? So it says that gas exchange is defined by the process which oxygen is transported to the cells and carbon dioxide is transported from the cells. Pretty simple, right? So if you take oxygen to the cells but you don't get carbon dioxide back, do you have an exchange? No. And if you can't get oxygen to the cells and they're storing up carbon dioxide, do you have an exchange? Okay? Now, if a patient is holding carbon dioxide, are they going to become alkalotic or acidotic? Why? Because CO2 is an acid. Very basic, right? I wish we could play our ABG Jeopardy game, but we can't. No time. So when we talk about this, these are the respiratory emergencies. These are the ones that have to be fixed quickly because you're going to lose that oxygenation perfusion and then your patient's going to die, which we don't really want unless we don't like them, and then that's a whole different issue. But when you go through this, there's certain groups that have higher risks for certain problems. The first one that we're going to talk about is pulmonary embolisms. Have y'all ever seen anybody that's died from a PE? What do they look like? Can't say dead. Okay, they look deceased. They look peaceful. No, they don't. They're dead. No, just kidding. What do they look like? What is a hallmark feature of somebody who has passed away from a PE? They're what? They're purple. From where? From the nipple line up, they are just as blue or purple as you ever want to see. And that is a severe pulmonary embolism, right? Obviously, if they're dead, it was pretty severe. Was it something that we could have done? Can we cause a PE? How? Yeah, air can cause a pulmonary embolism. You can have a fat embolism. Yeah. Anything that obstructs a pulmonary artery can create an embolism. So, if y'all want to kill somebody, that syringe full of air into the carotid artery will do it. It's kind of cool. But you will be found out because not many people can do it. So don't do it. All right. So we're talking about gas exchange, and the interrelated concepts are perfusion and clotting, and we'll talk about that in just a minute. Why clotting? Because if your pulmonary embolism is caused by a blood clot, what can we do? We can shoot them. With what? Okay, heparin won't dissolve a clot, though, will it? What will heparin do? Keep them from. So what else do? We could do TPA. streptokinase, or whatever it is, these clot-busting drugs that dissolve them, because if we dissolve them, it reduces that patient's risk for a PE, right? Simple. Simple, simple, simple. All this is simple. Okay, so the image to the right shows a pulmonary embolism. Can y'all see it? You see this clot right here? So what happens is something came out of here, through this pulmonary artery, and wedged itself here. So now, none of this is being perfused, right? You're not having any gas exchange. That patient's in serious trouble. So you've got to do something to clear this out. And the thrombolytics will do that. They can be targeted. But it can be solids, liquids, air. It doesn't matter. Anything that obstructs that circulation is going to be your issue. So we're going to talk about what is that patient going to look like. I'm a big latte person. Not that I drink them, but do you know how to use the latte system for your patients? Okay. Might want to write this down. Not because it's all that brilliant. I stole this from another instructor, by the way. Why? Because I can. We are not proprietary. L, what does my patient look like? Signs and symptoms. Right? Somebody tell me what a patient with a kidney stone looks like. They're hurting. How do they hurt? Back. Can you tell the difference between somebody that actually has a kidney stone and that just wants pain medicine? You can, can't you? Because what's one of the questions you're going to ask them? Do you have a history of kidney stones? Well, yes. My next question is, have you thrown up yet? Because they always throw up. And it's usually the big guys that are acting like a... Never mind. Okay, so the A. What are my assessments? If the patient comes in with a kidney stone, am I worried about his great toe? What am I looking for? Hematuria. That's a good one. What does that mean? Blood to pee. Okay? All right. I'm going to assess his pain. I'm going to assess the length of time that he's been doing this. All this kind of good. That's my assessment. All right. So my T. What tests? What can I expect that healthcare provider to order? Okay. UA, CBC, CMP. A who? A KUB. What's a KUB? A kidney, urine, or bladder X-ray. Do we need to do a CT scan of his head? No. Okay. Medicare won't pay for it. Okay. So what are my treatments? TREATMENTS. All right. What am I going to do for him? Fluids and pain medicine. And what else? We might give him an antiemetic. I don't like to. I just like to throw up. What else? We're not giving them lithotripsy. We're going to give them a strainer, but that comes later. What about Flomax? Open up them ureters. Get that stone on out. What we want to hear is that tink when it hits the... Well, we don't want to hear that because we want to catch it in a strainer, but you see where we're going. Okay? Now, how do I evaluate? And educate my patient. Increase fluids. Quit doing this. Don't do that. Quit smoking. Lose some weight. Drink a bunch of beer. Whatever. Whatever you got to do. And how can I tell if whatever I've been doing is working? They what? Okay, they pass it. Their pain level goes down. They're not crying on the floor anymore. The blood is cleared up. Usually it's microscopic. You can't see it anyway. But if you'll use this with your conditions, you can figure out what you need to do for your patient no matter what it is. Because we can go from kidney stones to pneumonia to asthma. Doesn't matter. But it gets important when we start talking about a PE. Okay? So now we get a video. Why? Because
Welcome back, future nurses. It's Christine from Nurse in the Making, and today we're going to talk about, which stands for pulmonary embolism. If you're following along in the MedSurg flashcards, I'm in the cardiovascular section on the card PE. Let's get started. By talking about what a PE is. PE stands for pulmonary embolism. This falls beneath the large umbrella of a VTE, which stands for venous thromboembolism. These are clots which occur in any vessel of the body. DVTs, deep vein thrombosis, and PEs both fall under that umbrella of VTE. I have an entire video talking about DVTs. A link should be popping up if you want to check that out. When a clot sits in the leg as a DVT and it dislodges, it can travel upward into the lungs, causing the pulmonary vessels to become blocked. And this is when it becomes a PE. When a vessel is blocked, gas exchange cannot take place, and this is dangerous for many reasons. A pulmonary embolism can also be from an air bubble which has entered the bloodstream. This could have happened from an accidental injection of air from a syringe. It also could happen from going to the surface too quickly while deep sea diving or from trauma. PEs can also be caused by small fat deposits, but this is very rare. The point is, any of these things, air, fat, or clot, can block normal blood flow, which cuts off much needed air exchange. So who is at risk for developing a pulmonary embolism? Well, first off, a patient already diagnosed with a DVT is at huge risk for developing a PE. If that clot breaks off and travels upward, it can cause a PE. Other risk factors include trauma or surgery, any disruption of blood flow. A hypercoagulable state, you want to think pregnancy or oral contraceptive use. Immobility like bed rest, bedbound patients, these can all increase someone's risk for developing a PE. But again, the most common cause are those blood clots or a dislodged DVT. Diagnosing a PE is very similar to diagnosing a DVT. Remember, both these sit under the VTE umbrella. So a D-dimer lab test will likely be ordered to check for that protein fragment which is sitting in the blood, telling us a clot is somewhere to be found. An elevated level or a level greater than 0.5 should raise a red flag. Since a D-dimer test only tells us there is a clot somewhere in the body, we need to do a CT scan and a chest x-ray to visualize the lungs and locate exactly where that suspected clot is hiding. When a patient has a pulmonary embolism, their symptoms can be alarming. Some things to look out for are shortness of breath, rapid breathing, which makes sense because the body is trying to compensate for that blocked airway. The patient will have an increased heart rate as the heart works harder to compensate. Oxygen saturation will go down since the patient's not getting the oxygen that they need. Often these patients complain of chest pain, they may feel anxious, restless, or afraid. Some patients will experience a sense of what we call impending doom. This can actually happen for a patient with blood clots where they are overcome with the feeling that something bad is about to happen. If a patient ever mentions this, act. Take this seriously. The body works in amazing ways, and as a nurse, it is your responsibility to listen and advocate for them. Since pulmonary emboli can be life-threatening, once they are found and diagnosis, treatment begins immediately. Heparin will likely be administered, usually by an IV drip, to prevent the clot from growing in size and to prevent new clots from forming. Nursing tip is that heparin is a high alert medication, meaning 2 nurses will need to verify this drug. Thrombolytics, which are medications to help dissolve the clot. Sometimes these clots dissolve on their own, but treatment will be decided based on what is seen in those diagnostic tests. If it's needed, surgical intervention might be necessary. A surgical embolectomy may be used. Let's break apart that word. Ectomy means the removal of, and emboli means a clot, so it's just removing the clot from the body. Much like a DVT or any unwanted clot, we want to prevent them from even forming in the first place. Well, how do we do this? The use of TED stockings and compression devices help promote that blood flow, especially when in bed or they are post-operative. We encourage leg exercises and early ambulation for those post-op patients. This is extremely important. We do this to get the blood moving. If someone will be traveling for a long flight or a long car ride, remind them to stand, walk around, or perform simple leg exercises. We want to encourage our patients to stop smoking, since smoking hurts our vascular system. You want to educate your patient about any anticoagulant therapy if ordered. Things like heparin, warfarin, Lovenox. These are very important medications, and these patients should understand the importance of taking them when scheduled. But something to know is that treatment is very different than prevention. For prevention, we want to get them up and moving. But for treatment, it's pretty much the opposite. We want to do everything in our power to keep that clot in the same spot. Isolate it and prevent it from migrating anywhere. So for treatment, we think bed rest, avoid massaging the area, avoid heat, avoid anything that can open up the vessels or could break up the clot, causing it to go straight to the lungs. Don't forget to subscribe to my YouTube channel for weekly nursing school videos, daily nursing.
Okay, so that pretty much summed it up, didn't it? Pretty simple. So, prolonged immobilization. We don't have these people, do we? What kind of people are they? Surgical patients, chronically ill. Who else? Do what? Coma patients. A lot of your unit patients are going to be like this, aren't they? How many of y'all see the unit patients up running around? So that's a major risk factor if they've got a central venous catheter. Why? Okay, if they clear it with heparin, is that really a big deal? That's going to keep them from growing. But what else could happen? Air. You could have an air embolism. You could have trauma to the site. If you don't flush them properly, clots will develop at the end of these catheters. And they can break loose and do all kinds of weird things. That's why you follow your protocols. Surgery patients, we talked about them. See, women just have it bad. Because y'all are on birth control and you get pregnant. Not at the same time, but... That's why we teach you about antibiotics and them pills. Y'all just don't listen. Whatever. Old people. Why old people? Because we old. We can't help it. What do old people do that young people don't do? We sit a lot. How many of y'all know them old people sit down and all of a sudden they fall asleep in their chair? That's me. Okay? General genetic conditions that increase blood clotting. And a history of thromboembolism. Which do you think are the most at risk? The history. They're already there. They know. Their body is already making these things. So if you know that they've got this, if they come to your clinic and say, yeah, I've got a history of DVTs, and you look at their med list, what is one that you're going to expect to find on there? Warfarin maybe. What else? Who? Plavix? Eliquis? Xarelto? What's the other one? Is it a Rixtra? Whatever these new generations are. Okay? And we'll talk about these in a minute because that's the pharmacology part of this part. So if they are on heparin, what test do we use? PTT. If they are on warfarin, what test do we use? The PT. If they are on enoxaparin, what test do we use? None. We use that religious test. None. Why? Because it's a low molecular weight heparin. There's no test to see how thin your blood is. But we're astute nurses. How do we know if they're having too much enoxaparin? Who? Petechium. What's that? Bleeding. Where? At their gums. When they brush their teeth. We hope they're brushing their teeth. Because then, if they don't, they have the Zachlys. Y'all know what the Zachlys are? It's when your breath smells exactly like your foot. Okay, so bleeding at the gums. Where else? Their nose. How many of y'all get nosebleeds? None of y'all. Oh, one. Okay. You're weird. Okay. Where else? It's a constellation. The constellation Uranus. Urine. Stool. All these places that you know to look for bleeding when patients are anticoagulated. It's the same thing with your new generation blood thinners because there aren't tests to check and see how thin the blood actually is. So you got to go by these secondary signs and symptoms. You have to. Because if you don't, your patient will not do well. By the way, what's the definition of a hemorrhage? Any uncontrolled bleeding. Right? Well, what if it's the nose? Is it uncontrolled? Yes, it's a hemorrhage. Well, what if it's out of his rectum? Is it uncontrolled? Yes, it's a hemorrhage. What if it's because his arm was chopped off? Yes, it's a hemorrhage. It's uncontrolled. Can people die from a nosebleed if it's uncontrolled? So you have to be aware. So when your patient is on these anticoagulant therapies, you've got to be aware of what to do. If they have that test, if they are on heparin, you can do that PTT and you can determine how thin their blood is. If they're on warfarin, you can do the PT or what? It's a PT INR. What's a normal INR for somebody that's not anticoagulated? 1. Is that what they told y'all? What did they tell y'all? Okay. Okay, so if I'm not anticoagulated, my blood should clot. I should have an INR of 1 because that's normal. But if I've got an INR of 2, then it takes my blood twice as long to clot. That means I'm anticoagulated to a certain extent. And the doctor will say, I want their INR of ... But if it's 1, you ain't in that ... You are normal. You are you are non-anticoagulated. Does that make sense? You're normal. Your blood ain't thin. It's thick. So if the doctor says, I want their INR of 28, which they don't because they would be dead, and their INR is 1, then you have to hold whatever test you were fixing to do or not do it. Make sense? Cool. Okay, lifestyle changes. We already talked about that. Quit smoking. Why? Who? What does that mean? Well, why does that have anything to do with it? Because of nicotine. If your blood vessels are smaller, is it easier or harder to get the blood to flow through it? Harder. So, if I got clots, what's going to happen if my blood vessels are small? They're going to get stuck. Okay. There you go. That's why. What about reducing weight? Flabby people ain't got no good circulation. Somebody tried to explain to me one time that like 5 pounds of fat has an extra mile of blood vessels in it or something or other. Now, I don't know if that's true or not, but that made me think that's a long ways to go. So my heart has to work harder. So get on the treadmill. Take the stairs. By the way, you that are with me at Anderson's, we take the stairs very quickly. All right? Become more physically active. Well, that has something to do with the reducing the weight thing. Because if we improve our circulatory system, we have fewer problems. We are a sedentary country. You know why? Because Mama and Papa don't make you get out in the garden and hoe weeds from dusk till dawn, or dawn till dusk. Or carry, or throw hay bales, or whatever country people do. Okay? But we don't. We're not as active as we are because of phones, computers. Who? TikTok. Okay. But everything is automated. You know, we're just not as active as we used to be. All right, if you're traveling, drink plenty of water, okay, because you want to make sure that you don't get dehydrated. Change positions often. Avoid crossing your legs. Get up from sitting 5 minutes each hour. How many of y'all have ever tried to get up on an airplane? That is an act of Congress. It really is. But you got to do it, especially if you're on long flights. How many of y'all go anywhere by car? How many of y'all put your feet up on the dashboard, in the front seat? Stop it! You ever seen what happens when an airbag comes out and your feet are up there? Your hips end up in your neck. But you got to get out and move. It's awful. If you've ever seen that happen, you said you have.
Like her lower leg bones, like they protruded out of her kneecap.
They'll do that. It'll also dislocate the hips, which creates a whole different issue. You are much shorter after this procedure, though. But you got to get up. You got to move. You got to get the circulation. Even that lady that was talking a little while ago said you got to move. How many of y'all have seen that commercial for that little stupid thing that you sit at your desk and it's automatic and it makes your feet go like this? Really? Are you that lazy? My goodness. And if you order now, you can get the deluxe version that does it faster. Who cares? Get up. Walk away from your desk. Go gossip at the water cooler like everybody else used to do. That's why people used to not have these problems. Now everybody just texts. Did you see Sarah? Can you believe she was wearing that? But we got to move. We got to move. We got to move. Get that circulation going. All right, now we're going to assess them because we think that they have a PE. What are they going to look like? What's their respiratory rate going to do? It's going to increase. Why? Because I can't breathe. Because I've got something that is impeding my perfusion, my end organ perfusion. Usually it's the brain. And when the brain starts lacking oxygen, your body goes crazy. So what does your heart try to do? Is it going to go up or down? Up. Why? Okay, circulation. But it's trying to do more with less, right? Oxygenation and perfusion are like a train. We load up the train with the oxygen and then they carry it on the tracks to where it needs to go. Well, if we can't get the train but half full, it's got to go faster. So your heart's going faster. Y'all buy that? And that's what's going to happen. So if you see your patient and they were good a little while ago and now they're going, they even sound like a train. Woo-woo. But they're breathing faster. Their pulse rate's going to be up. How often do we check vital signs? Depends. Every 4 hours is standard on a med surg unit, isn't it? Or something like that? Because don't we check them at 8 right before we go to lunch? Okay, there you go. All right. Anxiety. What does that mean? They're going to freak out. How many of y'all have seen people that have an oxygenation issue and they are Betsy Bug crazy? Because their mind is saying, look, Sugar Bear, you can't breathe. We got to do something. You're starving me. I wasn't that smart to begin with. And now you're making it worse. So they are anxious. That change in LOC is a prime sign and symptom that they are having an oxidation issue for whatever reason. Now, if they are fat, pregnant, let's see, on birth control, and have a history of DVTs, I know where I'm looking. So then we're going to draw some labs. How many of y'all remember your ABGs? Everybody raise your hand. Okay, you just lied to me, but that's okay. So they're going to have a low PCO2. Why? Why a low PCO2? We're getting air in, but we're not doing the exchange, so the carbon dioxide ain't coming out. So what's a low PCO2 in your ABG panel? Less than 35. Okay? You're going to get a troponin. Y'all know what a BNP is, right? Who says yes? Who says no? Yes. What is it? Oh, I thought you said yes. It is not cardiac specific. That is how you do what? What does a BNP measure? A BNP checks for fluid overload. When somebody is in heart failure, they will draw a BNP. Do not make me say that middle word because I can't. Normal is less than 100. You find these CHF patients, they will have a BNP of 7, 8, 9,000. But you're going to draw it to see if that's the reason they're short of breath. Because that's that key. They're short of breath and their respirations have increased. Their pulse has increased. Well, let's just do some more vital signs in about an hour. No. When your client starts having these changes, you need to act. Because if you don't, that's failure to rescue and you're going to lose your license. Merry Christmas. If you see your patient struggling, do something. Well, what are you going to do? What's an easy thing you can do? Who? Raise the head of the bed. Put some oxygen on them. Does that help? I don't know. It depends on the cause. But it's something. Because here's the deal. If you increase their oxygen from room air to 2 liters via nasal cannula, do you need an order for that? No. But you're still increasing the oxygen content that they're getting, which is a good thing. Because they're not getting as much. What we're getting them might as well be the best, right? If I can't give a 3, it's going to be 3 full ones as opposed to 18 half-empty ones, which the math on that doesn't really work out, but just go with it. And then we're going to do that chest x-ray because we're looking for what? We're looking for a blood clot, or we're looking for something that's impeding perfusion in the lungs, right? Because is a blood clot going to look different than pneumonia? Is it going to look different than COPD? Is it going to look different than fluid overload? Absolutely. But that's definitive. That's our test. All this is our test. Oops. Stop. Whatever. But you got to know what you're dealing with. Because if you don't, your patient's going to die. All right. So, we are going to do a pulmonary embolism analysis. We're going to analyze the cues and prioritize hypotheses. Whatever. We're going to take care of our patient. So what is hypoxemia? Y'all going to say it loud because I'm old. Hypoxemia is no oxygen in what type of blood? Venous or arterial? Arterial. Why does that matter? Yeah, because if it ain't getting oxygenated when it comes out, just think about it. When the blood leaves the heart, it leaves through what mechanism? Going to the lungs. The right or left ventricle? Dear Lord, let me rephrase this. Okay. It's going to the lungs, so it's leaving which ventricle? The right. Okay, thank goodness. All right. So it goes to the lungs, but if there's a blockage, it can work its way around, but it's not getting oxygenated, right? So it leaves the lungs and comes back to where? The left atrium. And then it goes, hey, we're going to drop through this hole in the bottom, right? Into the where? The left ventricle. And then it goes out to the body. But what does it not have with it? It forgot its luggage. So now you're sending deoxygenated blood into the arterial system. What's the only system that's supposed to carry deoxygenated blood? The venous system. We're backwards. We haven't done it. Okay, low blood pressure. Why? Why do you think? Okay, decreased output. Why are we decreasing output? Okay, maybe. How many of y'all have a John boat? How many of y'all have ever seen a John boat? How many know somebody named John that has a boat? Okay. A canoe. Make more sense? Okay. Y'all are going, where is he going with this? How is the heart supposed to be? Like this. Boom, 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 boom. Right? So when it does this, boom, what is it doing? It's contracting, but when the top of the heart contracts, what does it do? It forces blood into the ventricles. It fills them, right? Okay. Y'all got that picture. Now if it's going, is it filling the ventricles? No, because the bottom of the heart's beating too fast. It is like trying to bail out a canoe with a teaspoon. So it's not filling. So you're going to have hypotension because, one, there's not enough blood coming out of the heart, and you're going to have a decrease in cardiac output, which is going to make you even crazier. Your anxiety level is going to go up. We'll get to the bleed in a minute. But you see why. This is a cascade of events. Because when you get behind, if you haven't noticed that they're having trouble breathing, when they start compensating, you're going to lose that cardiac output. You're going to bottom out all of that stuff. Your cardiac output, your BP. Then you got to do a bunch of weird stuff. We ain't got time for that. It's break time. We got a potluck in the nurse's lounge. But you're going to have that anxiety because you've got that decrease in cardiac output as well. And it's going to affect that LOC. So when your patient is anxious, breathing fast, low blood pressure, because we're going in to check it, because if somebody is breathing like that, you need to get a set of vitals because you're not going to pick up the phone and go, Dr. Mutzenheimer? Yeah, this is Jeff. You know Miss Johnson in 236? Oh, you don't? Me either. Oh, I don't know what her vital signs are. She just looks terrible. I just thought I'd call you. What is he going to think about you? You are a stalker. And you just want to talk to him. Weirdo. But no, you're going to have that complete set of vitals. I think we should get a chest x-ray. That's going to tell me. And I think we should get some labs. A D-dimer. Because that's going to measure that protein, right? It's an inflammatory protein, by the way. All right, so why might they have a potential for excess bleeding? Especially if they've had a history of DVTs. They're on blood thinners. Okay. So we got to watch. Is it connected to that? Because if they're bleeding out, they're going to get the same symptoms, right? You're going to have a decrease in blood pressure, increase in heart rate, decrease in cardiac output, increase in anxiety. You got to know what you're doing. So, what are we going to do? We're going to do this. We're going to manage the hypoxemia. How are we going to do that? We have low arterial blood oxygen levels. I'm sorry. Had a mental thing there, a little mental break. We're going to give them supplemental oxygen. Well, how are we going to do it? If they're bad enough, we'll do it with this. Hooked up to an oxygen source, obviously. What are we going to start with? We're going to start with that? Well, if they owe us money, we really want to make sure that they're alive. So we're going to bag them like crazy. You're going to stay alive till you can make it to the bank. But we're going to do that. We're going to give them that supplemental oxygen in whatever means that we need to. We'll talk about intubation in a minute because it comes up with some other stuff. But we don't want to get to that point. We want to catch it early. We want to get those medications on board. We want to get those clot busters and that heparin or warfarin or whatever's. All right, we're going to control any bleeding that they may have because that's going to decrease their cardiac output. And we want to minimize their anxiety. We're going to sit and use therapeutic communication. Who's got time for that? We do. Because if you got a patient like this, you're going to sit in there with them. Now, we're not going to say, it's going to be all right, honey. Say, can't say that because you don't know. The only person that knows is up there. You're going to say, we're doing everything we can. You got to trust us. I mean, you'll say other things too. How many of y'all saw that airplane movie where the lady was freaking out and they just walked up and started slapping her? You can't do that. Although we want to sometimes. But you got to keep them calm too. Why do you have to keep them calm? They already working like crazy. We don't need no extras. So that's what we're going to do. And then we're going to set them up. Because if they've had a PE, they're going to be susceptible to getting other ones. Some of these are spontaneous. They don't know why. But we want to teach them home care management. Like what? Don't sit. I don't care if Days of Our Lives just came on. Get up and make you a sandwich. Do something. Get up, move around. Walk on a treadmill with General Hospital right there. It's probably the best thing you could do. We're going to teach them how to take their medicines, why to take their medicines. And depending on the medicine, we're going to teach them that they need to follow up with their doctor to get their labs drawn to make sure that we are where we're supposed to be. Because if not, what's the point of taking them? Well, I felt okay, so I didn't take it today. Well, you're an idiot. Don't you just want to say that sometimes? Sugar Bear, your blood pressure was 186 over 99. Well, I felt okay, so I didn't take my blood pressure medicine. Do you want a stroke? I mean, it's like what you want to say to them. You've got to explain to patients just exactly what their medications are for, why they're taking them, and the importance of it. If you tell somebody why, I guarantee you, you're going to get better compliance. You need to take your warfarin. Why? You just do. Because I said so. The doctor said so. Well, he ain't the boss of me. You're right, he's not. What kind of attitude is that? I know more patients that I see in the hospital that the nurses, when they were discharged, never explained their medications to them. Why? Do we want that much return business? Do they think that if we don't get those patients to come back, we'll go out of business? No. Because they're wearing this on their forehead. Now, every time? No. When you have a floor of 28 patients and 3 nurses, it's going to get missed. It shouldn't, but it's going to, and I guarantee it will. because they're just trying to survive. But if you are fully staffed, fully stocked, you have time to talk to your patients about their meds. And if you don't know about them, print something out and hand it to them. But you better make sure they can read. Y'all ever have patients that can't read? So what do? Read it to a family member. Pictures. I love pictures. Well, I like videos too, but pictures. I love pictures. That's why I hate y'all's textbook. I love pictures. But you got to make sure that they understand. Because have you really given them discharge instructions if you know? Okay, so how can we tell if what we did worked? See, we're down to here now. See how this works? Well, they maintain adequate gas exchange and oxygenation. They ain't blue no more. They done graduated from Papa Smurf to a troll. My grandkids love this thing, so. Because ain't trolls like normal color? Smurfs are all blue. Y'all don't even know who the Smurfs are? Okay, just checking. Y'all don't know who the trolls are? Have you got kids?
It depends on what trolls we're talking about. The old ones and the new ones are the different color.
But they ain't blue. Okay. All right, so they maintain adequate oxidation and gas exchange. That means, what are they going to look like? They're going to look normal. Their respirations are going to be improved. Their oxygenation is going to be improved. How can we tell? How can we tell that their oxygenation is improved? Their color. Their respirations are not 163. Okay, that's 2. They're what? How do we measure that? Rectal probe? How do we measure it? The SAC monitor. I just want y'all to think about all this. You're going to say, Mr. Hickpill told us we had one of these. You can measure it here. It's really long, too. But all these things are going to be better, right? So if it's on a test and their O2 sat went from 87 to 92, are we going the right way? Very good. All right. Does not experience hypovolemia and shock. We'll talk about that later when we talk about shock. But hypovolemia means what? No volume. It's all on the floor. Oxygenated blood on the floor is not helpful. So we're going to leave that. Remains free of bleeding episodes. Wait, what? We're controlling it. How? Our blood levels are in the normal range. Because what do we have to have? All right, so we got to have adequate blood, right? So we have to have a normal H and H, right? A normal RBC count. But how can we tell realistically? Because you're not going to walk around with this automatic thing going, my H and H is this. I mean, you're going to get your blood drawn at pretty regular intervals, but I'm not going to notice any bleeding. My urine will not look like Kool-Aid, the tropical punch flavor. If it's blue, that's a whole different issue, and y'all really need to be seen by an STI doctor. But their stool's not going to be black. It's not going to have red in it. My gums, all that kind of good stuff. My nose don't bleed. And when I get my INR checked, if I'm on warfarin, it's going to be where the doctor wants it to prevent me from having any more blood clots. I don't want it too thin, don't want it too thick. All right? States the level of anxiety is reduced. They ain't crazy. They got blood in their brain where it's supposed to be. We'll talk about that other later when you got blood where it ain't supposed to be. And they use effective coping strategies. They know the signs and symptoms. They know what to look for. If I start getting short of breath, if I start having, anxiety, I know I'm not perfusing. Somebody get me to somewhere where they can help me. They know that they need to take their medications. They're aware of the things that cause all the issues. Sitting too long, being obese, taking birth control pills, being pregnant, which, I mean, you can't really do anything about being pregnant except for habit, which occurs later, but all the things that they need to do to cope with this situation, plus you put them in touch with a support group. There is a support group for everything. And it's easier to talk to people that have been there. Well, how did you feel when you had that PE? Well, I felt this, this, and this. Help them. Is that your job, to help them with that? Absolutely. Because if you don't know, who can you send them to? Well, somebody, who would know, though? You're at the hospital. A social worker. A case manager. Look, you don't have to know everything, but you do need to know where to send them. And we don't want to send them to the morgue. All right. We're going to stop here and we'll get into ARDS in a minute. Y'all got any questions?